goes in session at 11 o'clock. So we do have to finish up by 11. And with that, instead of taking the roll, since we have so many new members that are here today, and I want to welcome all the new members on both sides, Democrat and Republican, to the committee. This is our first hearing. I thought we might just go around the room and let everybody just say hello, identify themselves, and let everybody know where they are. And we might start off with Christine.
Hi, I'm Christine Howard, and I am from Chester County, the 167th District.
Morning, everyone. My name is Jim Gregory. I represent the 80th District, which is most of Blair County.
Good morning, everyone. My name is Barb Gleim. I represent the 199th, which is Cumberland County.
Good morning. I'm Natalie Mahalik. I represent the 40th District. It's Allegheny and Washington counties.
Good morning, everybody. I'm Todd Polinchak. I represent the 144th District, which is in Central Bucks County.
Good morning. I'm Lori Muskorski. I represent the 30th District. It's the Northern Allegheny County.
Mike Jones, 93rd District in York County.
Maureen Madden, good morning, 115th District, Monroe County, the Poconos.
Joe Hohenstein, I represent the 177th District, which is the lower northeast part of Philadelphia.
Good morning, Isabella Fitzgerald. I represent the 203rd Legislative District, Northwest Philly.
Stephanie Borowitz. I represent Clinton and part of Center County in the 76th District.
Jim Struzzi, 62nd District, Indiana County.
I am Melanie Brown. I direct the committee.
Doyle Heffley, 122nd District, Carbon County.
Gene DiGirolamo, the 18th District in Bucks County.
Angel Cruz, Philadelphia County, 180th.
Eric Nelson, 57th District, Westmoreland County.
Good morning, everyone. Mike Schlossberg, 132nd District, Lehigh County, City of Allentown. It's good to see you, Lane.
Good morning, Stephen Kinsey, Philadelphia County.
And John Hershey, the 82nd District, Juniata, Mifflin, and Franklin counties.
Okay, before we start with our testifiers, Representative Cruz, any comments? Would you like to say anything before the
I
committee?
just want to apologize for being late, but I'm here.
Okay. Again, Human Services Committee in this issue of addiction, especially when it comes to the heroin and opiate epidemic and crisis that we're experiencing all across Pennsylvania. I mean, we've done an awful lot of work over the last few legislative sessions, and even though this problem it appears to keep getting worse, although we're getting some reports of the deaths being down in some of the counties, the thing that keeps me going is that if it wasn't for the good work that we have done up here in the legislature, the past 2 or 3 legislative sessions, that it would probably be 2 or 3 times worse than what it is today. So that keeps me going, and we've got the hearing today is on 2 really important issues and 2 bills that have been sponsored by my colleague, Representative Doyle Heffley. So I am going to let Doyle chair the committee today, since most of the testimony will be on his 2 bills, which are warm handoff and bed registry. So Doyle, I'm going to turn the hearing over to you, and you can chair the rest of the hearing. Thank you.
Thank you, Mr. Chairman. Obviously, this is an issue that affects every county, every part of the state, both rural and urban. And it is something that we need to continue to address. A few months ago, we had the pleasure of sitting down with Lehigh County officials and going over their Blue Guardian program, and then we worked with staff to develop a warm handoff legislation, and this is the first hearing on that. So we're going to hear from all the testifiers. I want to thank everybody for being here, and I want to get right into our testifiers today. So if we could start with Lehigh County, Julia, is it Kosis, Director of Regional Intelligence and Investigation Center Office of the District Attorney of Lehigh County, and Lane Turner, Drug and Alcohol Administrator for the Single County Authority in Lehigh County. So if you could do your presentation. Thank you.
Thank you, and thank you for the invitation to be here. The Blue Guardian program was developed to include multiple facets and sectors surrounding substance abuse disorder, specifically opioids, and the impact to our community. We looked at the issue as if it were an ecosystem, so that any change we made to one area would not upset the balance elsewhere in the community. The Blue Guardian is a collective impact approach that collaborates across sectors to address these issues in unison. For the purpose of this presentation, the scope of the common agenda is limited to two partners, law enforcement and the hospitals. Law enforcement core functions are community safety and community health. Through creative collaboration, we have the ability to leverage these partnerships. Supporting the core functions and leveraging partnerships have created three unique programs. The City of Allentown Police Department's Outreach Program, which averages 250 monthly street-level contacts, Upper Macungie Township's Police Department's Evidence-Based Hub. If a disaster is identifiable, it may be preventable, and the Certified Recovery Specialist Ride-Along Program. As the police departments across the Commonwealth are participating in the naloxone program, fundamental questions were asked. How can law enforcement be further supported? How can we solve the data delay? And can the individual and or their family be supported? These answers required us to know where the save occurred, when the save occurred, where the individual is from, and which hospital did they go to. Of these questions, we had one easy answer. We knew which hospital they were going to after the save. The other answers proved more problematic. Starting with the which hospital that we knew and building off the core function of community wellness, healthcare partnerships were leveraged to create specialty programs within the hospital setting that will target the specific need of the individual who overdosed, received naloxone, or required emergency medical attention because of drug use. As a result, the programs listed here have been established or are in the final planning phases. As attendees are well aware, a warm handoff process for opioid use disorder from the emergency department to treatment is the benchmark across the Commonwealth. The fundamental directive is for a warm handoff to occur, the referral must be made only from the emergency department and it must be opioid related. Lehigh County has expanded this directive to include referrals from all hospital departments and to include all substances of use. Lehigh's expansion of the warm handoff directive has allowed over 2,200 hospital-based referrals. Because we eliminated the barriers of drug of use, where the referral in the hospital had to come from, and the county of residence, we are a more meaningful partner to our hospitals. A larger number of individuals are accessing treatment, and we are collaboratively working towards a healthier community. In a 24-month period, over 850 individuals were provided the appropriate access to treatment from the hospital. Unfortunately, the 2,200 referrals represent under 30% of the individuals entering an emergency department because of a substance use disorder. Most individuals refuse services and elect to return home. As we know, returning home without addressing addiction can have deadly consequences. However, as you will see later in this presentation, we are able to leverage the coroner as a partner to further identify needed resources. For those individuals involved with a police naloxone reversal and refused treatment access while in the hospital, the Blue Guardian was developed, a joint police officer and certified recovery specialist home visit to reconnect with the individual and or provide family support, but most importantly, being able to offer immediate access to treatment services. This program went live on March 1st, 2018. Of the more than 300 naloxone saves in that period, 138 home contacts were made. Most individuals saved through the naloxone program resided outside of Lehigh County, and therefore home contacts could not occur. It is important to note of the 138 contacts, the team successfully met with 52 individuals. Of the 50 individual face-to-face meetings, 34 individuals entered treatment. The lessons learned when the face-to-face contacts are made, Over 60% of the time, individuals enter treatment. This speaks directly to the power of the joint police and CRS contact. There are 6 basic steps to the Blue Guardian. First, the police administer the naloxone. Second, the police enter the information into the Blue Guardian application. From there, the data is sent to the PA Odin application. A naloxone use report is generated. We have requested information be entered over and above what is collected by PA Odin into the naloxone use report. This would include the incident number, the individual name, the individual's address, location of the overdose, what hospital and EMS group were provided transportation. Third, the SCA receives the notification of the naloxone use report. Steps 4 and 5 consist of the SCA submitting a referral to the certified recovery specialist in order to appropriate municipal police department and arrange a home visit within 48 to 72 hours. If during this home visit the individual or family agrees to additional support and/or treatment, immediate warm handoff occurs to the Center of Excellence. If a family or individual declines, it is noted in the police contact summary. This process is critically important as it resolves the 3 previously unanswered problematic questions: how to support the police, who is the individual, and where do they live? With this framework in mind, Julia is now going to provide an overview of the application itself.
All right. So we leveraged the technology that we had already developed by including the Blue Guardian application as a component excuse me, within our larger illicit drug identification and tracking system. This system tracks drug deaths, which you can see on the screen here, which is entered by our coroner's office. It also tracks our controlled drug purchases and drug-related complaints by our drug task force. And the coroner is actually a very important partner in our collaboration because it's his data that allows us to gain better insights into the substance use disorder that's actually happening within our community. So we capture information on decedent demographics, date, time, and manner of death, as well as toxicology results. This data is then used to populate the coroner's dashboard within the application, and it allows us to see drug deaths over time, the day and time of day that drug deaths are occurring, as well as deaths across municipalities within Lehigh County. We were also able to incorporate what is called an active metabolite database into the background of the coroner's part of the application. This allows us to roll up toxicology results to a parent classifier, so we have a better understanding of what are the types of drugs involved in these deaths. So a good example would be a toxicology report will come back and list a substance called 4-ANPP. And that actually is a fentanyl precursor chemical. So we'll take that and we'll roll it up to the parent classifier of fentanyl, and that way we have a better understanding of how fentanyl may have contributed to some of these deaths. We're also able to track the migration path regarding a decedent's place of residence to where they died. And then the drug task force section of the application is where we will track all of the controlled buys, drug complaints, and any identifiable markings of heroin brands that detectives will confiscate during a drug investigation, or a naloxone administration event, or even a drug-related death. So this is what the identifiable markings section looks like, and this is where all the heroin brands are listed that we find. We'll also list if there were overdoses associated with a particular brand or deaths. That way that we can then alert our partners of what we're seeing in the field in our area. And we were able to incorporate some natural language processing techniques into the drug task force section of the application. And what it does is it runs over the police incident narratives to find new and trending drug patterns across the region. So what
Could you, excuse me, could you just hold the mic just a little bit closer? Some people have indicated that a little bit problem hearing, so thank you.
So having this technique run against police incident reports also gives us a deeper insight into the substance use disorder that's occurring in our community. And what you're looking at here is an example of that technique that we put against police reports from 2015 and 2016. And I don't know if you can see it because it's pretty small on the screen, but that's when we picked up on K2 and synthetics that were trending in our region back at that time. Okay. So the Blue Guardian application allows us to track who was administered naloxone, by which agency, which hospital they were taken to afterward, and where the individual resides. All police officers in Lehigh County have access to enter this information in Blue Guardian, whether it's at their desktop, at their home department, or within their patrol vehicle. And the Blue Guardian system captures information on date, time, and location of the naloxone event, victim information, name, address, demographics, any evidence that may have been secured on scene, such as drug paraphernalia or identifiable markings, which would be the heroin brands that I had showed you earlier, the details of the naloxone usage, as well as pre and post naloxone symptoms, and administrative details for inventory purposes. So all of this information that's captured, it helps our single county authority try to coordinate that Blue Guardian visit with law enforcement and a certified recovery specialist so they can do follow-up with treatment options for the individual. And then once officers complete the Blue Guardian form, a portion of that information is then sent up to the Pennsylvania State Police ODIN system. And we feel that our systems actually complement each other. So Blue Guardian is more detail-oriented, and it also contains clinical notes, which we need to do for treatment follow-up and support. So we're more operational and tactical. And we feel that the ODIN system has more of a strategic high-level overview, so you get an idea of where these naloxone administrations and drug deaths are occurring across the Commonwealth. The Blue Guardian dashboard also shows a migration path of where people are ODing. So we see a lot of rural communities coming into our larger cities in Lehigh County. We also see a lot of movement outside from other counties moving into Lehigh County and other states. The system also provides inventory management, which shows naloxone distribution, who received what, when, and the expiration dates. And it shows naloxone usage, which is calculated automatically as law enforcement enter the information in the naloxone event. And this information can be exported into Excel, which is really handy when we're doing our grant reports to the PCCD because they are the suppliers of naloxone for Lehigh County. And lastly, there's a section in the application that will track the treatment notes. So to show you this part of the application, we're going to actually walk you through some case examples. And while the data has been obfuscated, meaning the personal identifying information has been masked, the basic premise of the events have remained the same. Okay. So the first case is of Chauncey Stewart. Chauncey was a young man who was given naloxone by police and taken to the hospital. So if you look up on the screen, over on the right-hand side, under activity history, the bottom event has a blue cross icon. That represents the naloxone event. The next event above that represents a Blue Guardian visit that was paid to his home. Chauncey lived there with his parents. His parents were unaware of their son's drug use. The son refused the services that were offered. He actually became angry with our certified recovery specialists for outing his drug use to his parents. And then the next event that's listed above that with the yellow icon, that represents that a few days later he was unfortunately found dead in his bedroom by a family member. When we look at the toxicology report for Chauncey, it revealed morphine, 6-monoacetylmorphine, codeine, 7-aminoclonazepam, and fentanyl. And it also listed that his addiction started as recreational drug use. So being able to cross-reference the Blue Guardian information on Chauncey with the coroner report, like here, helps us gain, again, better insight into the problem. And then having additional information from our drug task force that might be able to link an overdose or drug death back to a particular dealer that's associated with a particular brand is even better. And that's why we purposely work to integrate these systems together. Our next case is of Marley's Patton. So Marley's was a young woman who was administered naloxone twice by law enforcement on 2 different occasions. Initially, we were unable to locate her, but eventually she was found, and she's actually been admitted into an inpatient treatment program that provides MAT. And Marley is still in treatment, and she's doing well. So the information that's entered into this section of the application, it may eventually have a status of closed, meaning the individual's in treatment, they did well, they're released back out into the community, they're healthy. But we will retain this information for if the individual should ever go back to using drugs and police need to administer naloxone again, the certified recovery specialists have the ability to pull this information up and see what we did with that individual last time around getting them into treatment, because maybe we can take a different approach and serve the individual in a different way. And then our last case example is of Cassandra Pope. She was a young pregnant woman who started out in treatment, was later administered naloxone. She went back into treatment and gave birth. She was administered naloxone again, went to jail on a probation violation, went back into treatment, and she recently died of a possible drug overdose. Cassandra's toxicology report is still pending, but it is noted that she started with prescription drugs and progressed to illicit drugs. So going back to the collective impact approach of the Blue Guardian program, we, law enforcement and healthcare, we really do have a common agenda in mind because we have a shared vision for a healthy community and our joint approach to treatment and support. We have continuous communication between our parties through the Blue Guardian application. It helps us identify service delivery gaps and needs either from the law enforcement end of the spectrum or from the healthcare end of the spectrum. And the district attorney and the Regional Intelligence and Investigation Center actually serve as a backbone organization for this program. And we help coordinate the efforts across all partnerships. And this is one of the reasons that we feel this program has been so successful. It's because we have the district attorney as its champion supporter and his resources to help make all this happen. We also tried to leverage our individual strengths so we're not duplicating efforts across our partnerships. And this allows for us to make a greater impact as a collective unit. And then lastly, the Blue Guardian application allows for data collection for consistent measurement to help align participant efforts.
The philosophy behind the Blue Guardian, its accompanying application, and spin-off specialty programs is meaningful across platforms. It can be applied to volunteer fire companies, identifying families in needs, and providing joint CRS outreach. It can be applied to EMS groups. It can be applied to church groups. Also has applicability with the mental health field. The Blue Guardian process engages the strength of our community to systematically work towards a system of shared support, ownership, and outcomes. Thank you for your time this morning.
Thank you.
Thank you for your testimony, and you will be able to stick around a little while then for questioning afterwards. Thank you.
So we'll have emergency room physician, Dr. Barbera.
Dr. Barbera. Everybody got to wake up now the lights are on. Our next testifier is emergency room physicians, Dr. Barbera. Thank you for being here today.
Thank you very much. Thank you. Ladies and gentlemen, on behalf of the Pennsylvania College of Emergency Physicians, I thank you very much for the opportunity to talk to you guys this morning. As you know, the emergency department is really the front lines of the opioid epidemic. There are very few people that have an opioid addiction that do not wind up at some time in the emergency department. So emergency physicians have been very involved with the Commonwealth and the local governments and the national even task force on developing strategies to mitigate the opioid crisis. Some include the warm handoff, some include medical assisted treatment in the emergency department, and other novel ideas such as inpatient observation for detoxification, starting people on buprenorphine, getting pregnant people that present to the emergency department on medical assisted treatment so that their children don't suffer from neonatal abstinence syndrome. So emergency physicians have been very involved with this, and we wholeheartedly support the warm handoff. There are some things that that I think on behalf of myself, Reading Hospital, where I am the chair at Tower Health Reading Hospital, we actually have the largest emergency department in the Commonwealth of Pennsylvania and a 24/7 warm handoff program that is funded through the community with a certified recovery specialist 24/7 in the department. I want to tell you a little bit why that's important to have it 24/7. We had a case several years ago before we went 24/7 where we had a young lady come in. She was 25 years old. She had 2 young children, and she had overdosed, and one of her daughters had called 911, and she had come in, and we had gotten her referral to treatment the next morning, and we had sent her home. And about an hour later, she came back having overdosed again and was deceased now. And we then had 2 orphans in our emergency department. And the ED staff sat around and we said, well, what did we do? We didn't really do any good for anybody. We felt like, oh, we got her an appointment tomorrow, but tomorrow was too late in this case. And we see a lot of, every day you open the newspapers and you see tomorrow is too late. These programs, to be effective, have to be 24/7. And the only shot that you have is when that person is in the emergency department. And someone needs to be right there and then able to take care of that patient. And we see this. So when we get a heart attack in, we don't send them home and say, okay, go see your cardiologist tomorrow. No, we don't. We take them right to the cath lab and we put up billboards about it and say, we're this good, and you see them everywhere about how great people are with hearts. We're not that good at doing that with overdoses, but we need to be, because it's the same time sensitivity there. Every hour somebody spends in the emergency department and does not get treatment is 1 hour less that they're going to be successful. The best shot at getting somebody into treatment is right after they stop breathing and right after they almost died. And I think that's important. The single county authorities need to be able to provide 24/7 coverage. Doesn't need to be on site. We have about 5 overdoses a day. It makes sense for us to have somebody on site, but there needs to be a process that there is an on-call system 24/7, and the single county authorities need to be empowered and funded to do such things. The one thing that I would say that is a little concerning is the warm handoff centers that are not in the emergency department that is proposed. I would be a little cautious about that, because many times we will get overdoses that have medical or traumatic injuries that have not been picked up in EMS. And so what will happen, and this is not a ding against our EMS colleagues, but what will happen is that they'll be called out for an unresponsive. Somebody will feel that there is a drug addiction and an overdose, and we'll find out after evaluating them that there may have been an overdose, but there could also be a gunshot wound. There may be a concomitant ingestion, that there is heroin, but there is something else. More than likely it's alcohol or something else. We see medical problems. People that stop breathing, that's a significant thing. So sometimes we see anoxic brain injury, we see stroke, we see rhabdomyolysis. We see a lot of diseases that go along with the overdose, that it's not really just a shot of Narcan and you're cool. I think that we would really be putting patients at danger if we said, okay, let's bring them somewhere where a physician cannot evaluate them. So I would caution us to do that. I think that at some point, with the right resources and those being structured well, that will work very well, but not in 2019, at least not today. The other thing about the legislation is the mandatory education. While I think that's important, I think each county is different. So I'm part of a health system and lead the emergency division for a health system in 4 different counties, and each of our EDs are different, and we see different people. So our warm handoff training is very different per our site. We have a hospital in West Grove, Pennsylvania that sees about 1 overdose every 3 or 4 days. And their warm handoff process is very, very different than Reading Hospital, where we see 3 a day. So I think that it's incumbent on the single county authority and the emergency department to develop together what their training looks like, because it's not a one-size-fits-all. And I think that if we try to make it so generic, we're going to lose the details. What is important, obviously, is treating this as a disease, is avoiding the stigma, and as empowering everybody from police, from pre-hospital, from emergency responders, from addiction therapists to notify or to address this as a disease and accept people as a disease. And that was something at Reading Hospital that didn't come that easily until there have been cases where it has become evident that this is a disease. When someone comes in and they have a heart attack and they continue smoking, we don't say, well, we're not going to treat you because you still smoke, and that's your own fault. But for some reason, people will say that when someone comes in with an overdose and say, well, that's your own fault. So I think our education needs to be around the fact that this is a disease, and whether or not we feel that someone brings it on themselves, there are many diseases that people bring on themselves, be it tobacco or eating or driving a motorcycle without a helmet, a lot of different things, and yet we treat them as diseases. And I would just advocate for that. One more thing that I think is important, and where the warm handoffs sometimes fall out, is the payers. So what we've done at Reading is we have a payer-blind warm handoff program, because we find out that when we get into insurance coverage, we're treating everybody different, because some insurances will pay for this and some will pay for this. And if you're not insured, that's the easiest, because then we can get somebody on public assistance and they'll pay for things. And by the time we're navigating through this system, what do you think happens? People get tired of waiting. They're going to go home. I'll come back tomorrow. Tomorrow doesn't happen in 50% of the cases. So we've got to, what we've advocated for, and what we do now is we say, you know what, we're going to get you into treatment. We've identified a need. We're going to get you into treatment, and we'll worry about the payer on the back end. And I think where this committee can really be powerful is to say, you know what, payers in the Commonwealth of Pennsylvania need to treat this like the emergency it is. And really the pre-auth and the saying, oh, you've already gotten your X number of days for this year, you'll have to wait till January 1st before you can go into treatment. Well, that's a death sentence for many people, and it's just not feasible. The 2 more things, I'm sorry, I'll be quick, is there does need to be a database that controls, and so we can see what our progress is. The one thing that I would ask is that the database, if it's to be developed, is developed much like the prescription drug monitoring program. I think if you find that each hospital or each EMR, if they have to develop their own, you're going to have a network of different databases that don't talk to each other, that are very ineffective, and that create huge administrative burdens. So if there is a database, and there needs to be a database, we need to be able to say that Junior came in with an overdose, and where can we send him now? And we need to have that at the tip of our fingers, much like we can find we can find a restaurant for lunch at the tip of our fingers and say, where can I get a reservation for 4? We can do that very easily. We can't find whether there's an open bed somewhere to get somebody detoxed. So I would advocate for that. And finally, the legislation calls for a task force, and I believe that emergency physicians really have a powerful place on that task force and can be very, very helpful as a member of there. And I thank you very much for your time. Thank you.
Thank you, Doctor.
Now it's this is your hospital, Leon.
And now,
Jillian
Jillian Beauchamp from Hospitals, Dr. Jillian Beauchamp from Lehigh Valley Hospitals, right? Okay. Come on, have a seat. Thank you for being here.
Good morning, Chairman DiGirolamo and the members of the Human Services Committee. I really appreciate the opportunity to speak with you today, and especially want to thank Representative Heffley for inviting me to speak and for all the important work you've done on behalf of those who suffer from substance use disorder, and in drawing attention to how the Commonwealth might better respond to the opioid crisis. I'm Jillian Beauchamp. I'm an emergency physician, toxicologist, and addiction specialist at the Lehigh Valley Health Network, where I've worked for the past 2.5 years. LVHN includes 8 hospital campuses, 3 in Allentown, 1 in Bethlehem, 1 in Hazleton, 2 in Pottsville, and 1 in East Stroudsburg. And with 7 emergency departments treating approximately 314,000 patients per year, we are truly on the front lines of the opioid crisis in eastern Pennsylvania. We are very fortunate to have in Lehigh County a strong, visionary single-county drug and alcohol authority that has worked hand in hand with our providers to find solutions to better respond to the complex problems in our community. Unfortunately, I'm not sure that that same strength is currently available across the Commonwealth. And for that reason, I commend the motivation behind HB 424, the warm handoff for overdose survivors, which hopes to bring best practices to all communities across the Commonwealth, as well as efforts to help providers identify available substance use disorder treatment beds throughout Pennsylvania in HB 596, Detoxification and Addiction Treatment Bed Registry. Substance use disorder needs to be managed as a disease, and that requires many partners working together to provide a full continuum of care across many support systems. And the Warm Handoff Initiative is often the first step in that continuum to make that connection necessary to bring that patient to the full complement of resources that lead to recovery. Since 2017, LVHN has been utilizing the Lehigh County-supported Hospital Opioid Support Team, or HOST team, in conjunction with the services of our own addiction recovery specialist to link patients to treatment for substance use disorder. Our newer medication-assisted treatment and connections program for pregnant women, also county-supported, initiated in 2018, have initiated medication-assisted treatment for over 70 patients and have linked over 60 pregnant women with substance use disorder to treatment. Altogether, these county-supported programs have linked over 1,100 patients to treatment. And we've really seen the difference that that makes in patients' lives as individuals who are struggling with a substance use disorder initiate their recovery journey and do the hard work of rebuilding relationships, getting back to work, and many of them returning to the community as recovery advocates. And despite the immense dedication of our single county authority to collaborate on these programs, we continue to face challenges in meeting the needs of our patients with substance use disorder due to limited resources throughout our region. Warm handoff programs rely on the availability of treatment providers as well as inpatient detoxification and rehabilitation beds. So again, I'd really like to commend Representative Heffley for reaching out to the provider community to ask for our input, listening to our suggestions. LVHN firmly believes that if seamless warm handoff processes were in place in every community across the Commonwealth, lives would truly be saved. I've been asked here today to speak directly about Bill 424, and I'll offer a couple of general statements, and then I'll be happy to answer any more detailed questions you have about details of the warm handoff, medication-assisted treatment, or any specific language or provisions in the bills. First and foremost, let me say I was pleased to see the recognition of the level of complexity needed across the many systems of care and responsibility that are expressed in the proposed legislation. It's that same level of complexity that gives me some pause about any rush to implement a law until a few fundamental questions are thoroughly researched and answered and then addressed in the bill. The first one being the Commonwealth's role in ensuring the necessary treatment and recovery support capacity to address the need for all overdose survivors. LVHN believes that this is the bedrock on which the success of all warm handoff initiatives rest. For this legislation to produce the outcomes it's striving for, we believe the Commonwealth needs to seriously evaluate and quantify the availability of treatment resources, as well as the adequacy of Medicaid reimbursement rates for those providing treatment for substance use disorder and behavioral health services. In light of the rising need, why aren't more treatment services springing up or expanding the number of beds? And what would a bed registry illuminate about the availability of facilities that provide care to patients under Medicaid or Medicare? We all know what the stats would look like if we counted the number of dentists in Pennsylvania and then compared that to the number who actually accept Medicaid-covered patients. We're really happy to see the legislation does reference reasonable and fair reimbursement rates, but without further research, evaluation, and detail, we're left to wonder how those terms will play out in the final analysis. LVHN wholeheartedly supports the creation of a task force to study those requirements needed to implement evidence-based treatments for substance use disorder, as well as overdose stabilization and handoffs. As a physician, I'm also acutely aware of other substance use disorders that are ruining lives and need equal attention to the opioid epidemic and could benefit from some of those same treatments. We also believe that the work of such a task force could better inform the mandates that are being proposed in 424, protecting against the potential for any unintended consequences and ensuring the desired outcomes in keeping with the intent of the legislation. I do want to take a moment to applaud the courage shown by including a reference to harm reduction services in House Bill 424. While sometimes considered controversial, I believe many underestimate the potential public health crisis that could result from inadequately addressing the need to reduce harm. Both in our Commonwealth and across the country, epidemics of opioid overdose deaths and hepatitis C infection are happening synergistically, with combined influences related to injection drug use. This is leading to increased transmission and progression of disease. In Pennsylvania, acute hepatitis C incidence across the state has risen 233% in just the past 4 years. And further, Pennsylvania ranks 10th in the U.S. for new HIV cases. As part of a multi-pronged approach to addressing these synergistic epidemics, harm reduction services are needed to combine things like naloxone distribution, linkage to treatment for substance use disorder, HIV and hepatitis C testing and linkage to treatment for those diseases, and referral to medical, social, and behavioral health resources, all in conjunction with programs like syringe services and associated education that help to reduce the spread of HIV and hepatitis C. And I was very happy to learn that the Pennsylvania Secretary of Health referenced harm reduction syringe services in her budget hearing testimony in front of the Senate Appropriations Committee. I do want to bring up just an example as a physician on the front lines of some of the patients that we see to illustrate these thoughts. So the other day, in taking care of patients on the hospital, we had a patient who was brought in by our Blue Guardian certified recovery specialist. He found the patient unconscious in his home upon checking on the patient after recently receiving naloxone by law enforcement, brought the patient personally to the hospital, and we were able to link that patient to treatment. That demonstrates the importance of programs like Blue Guardian, who directly address overdose patients and members of our community in the field. The second patient I saw was a patient who is a very high-functioning member of our community who was there for surgery and who went into alcohol withdrawal on day 2 after his surgery. Nobody knew he had an alcohol use disorder problem. And that patient, we were able to link to treatment, prevent further issues downstream, and get him back to the life that he's used to living. And that demonstrates that there are problems outside of opioids that we want to address as well. The third patient walked into our emergency department because they'd heard about our hospital opioid support team program. So without having overdosed, they came to us to ask for help, and we were able, through those resources, to link them to treatment. And that patient demonstrates that even beyond patients who overdose, there are patients in the community who we'd like to help before they get to the point of overdosing, before they get to the point of needing naloxone. The final patient that we saw that day had a serious bacterial infection related to their injection drug use. And by providing them the medical care that they needed, the stabilization at a medical center, we were able to meet them where they were at the bedside and to link them to treatment. And that patient helps us to illustrate how serious some of the sequelae are related to injection drug use, including serious bacterial infections. Many of those patients are positive for hepatitis C, and until we can link them to treatment, promote abstinence, get them the substance use disorder treatment they need, we aren't able to adequately address their hepatitis C, their injection drug use related infection, or to prevent transmission through shared needles out in the community. So in closing, I'd really like to thank you for the privilege of speaking with you today. I commend the committee for shining the light on this very important topic, and I'm happy to stay around to answer any questions you may have. Thank you so much.
Our next panel is the Public Health Management Corporation, Dr. Karen Dugash and Dr. Adam Brooks. Thank you for coming here today with your testimony.
Morning, and thank you for allowing us the opportunity to speak to you this morning. I'm Dr. Karen Dugash, and I'm a senior scientist and director on the Center of Addictions at Public Health Management Corporation. I've been conducting addictions research for almost 20 years. Much of my work currently focuses on the opioid epidemic and developing and evaluating strategies to reduce its impact, including warm handoff initiatives. Through this work, I've gained some knowledge and insight about different factors that can enhance or impede the success of warm handoff programs. I'm very excited about the Warm Handoff to Treatment Act as it recognizes the importance of connecting overdose survivors to effective treatment and seeks to develop standardized procedures and adequate funding mechanisms to help ensure the success of warm handoff programs. I would like to speak to you today about several ways that I think the legislation could be improved. As you know, there are effective medications for the treatment of opioid use disorder, including buprenorphine and extended-release naltrexone. Recent studies have shown that emergency department patients who receive buprenorphine prior to discharge are more likely to engage in substance use disorder treatment after they leave the emergency department. This research suggests that warm handoff success rates would be improved by including medications like buprenorphine in the warm handoff process, something that's not addressed in the current bill. Furthermore, because providers must complete a comprehensive training and receive a special waiver to prescribe buprenorphine, it's important to consider providing resources to help offset the additional costs that EDs experience. It is also critical to emphasize the importance of connecting individuals to facilities that provide medication-assisted treatment, given that it's the gold standard for treating opioid use disorder. Furthermore, the legislation seems to equate detoxification services with formal opioid use disorder treatment. However, research indicates that detoxification alone is not an effective treatment, and that providing detox alone may actually put individuals at higher risk of relapse and overdose. As such, the bill should include mechanisms to help ensure that patients successfully transition to the appropriate level of care following a detoxification episode. Like many others today, I believe that the bill could be improved by enhancing the monitoring and oversight of the warm handoff process. This includes increasing the number of target behaviors that are reported to the department, as well as the frequency with which reporting and feedback occurs. My work has found that the warm handoff process can break down at several points along a continuum, from individuals refusing to be transported to the emergency department to a patient leaving substance abuse treatment against medical advice. The legislation as written does not capture several of these key elements. Collecting the full range of data will allow the department to identify where gaps occur and where additional efforts need to be directed. And I would agree with the previous speaker that following a system, implementing a system like the PDMP approach would be highly successful. Furthermore, I believe the bill focuses on bidirectional annual reporting by providers in the department, and that this reporting would benefit from increasing. I think it should occur more frequently, possibly on a quarterly basis. This is of particular importance during the early phases of program implementation and would allow the department to identify performance gaps when they can more easily be addressed early on. In addition, collecting these data at more regular intervals could allow the department to reinforce high performers through some form of recognition or a type of an incentive program. The stigma surrounding addiction and the general lack of provider knowledge and training about addiction is a significant barrier to the success of warm handoff programs. The proposed legislation has taken several steps to overcome these barriers. First, it mandates training for both EMS and ED providers and provides financial resources to offset training costs. The work that I've done suggests that these trainings should be delivered on an ongoing basis with frequent booster trainings. Second, the warm handoff centers to be established through this legislation will likely be staffed by individuals who have more experience with and less stigmatizing attitudes about individuals with addiction, which is likely to further support successful transition to treatment. Regardless of where the person is being treated, it's critical that members of the care team have expertise in addictions and that they are sensitive to the experience and needs of overdose survivors. Finally, it's essential that the entire program be rigorously evaluated to determine its effectiveness and to identify important mechanisms of action. Given the magnitude of the current opioid epidemic, it's clear that there's no one single strategy to address it. We need to identify various points at which we can intervene with individuals to prevent, identify, and treat opioid use disorder. The time immediately following an opioid overdose represents a teachable moment to connect opioid overdose survivors to treatment. I believe that the proposed legislation has the potential to increase the success of Pennsylvania's warm handoff mandate, and I thank you for offering me the opportunity to provide you suggestions for how it can be improved. Thank you.
So my name is Dr. Adam Brooks. I'm a senior scientist and a director of research at the Public Health Management Corporation's Research and Evaluation Group. I work closely with Dr. Karen Dugash. Prior to joining PHMC, I also worked as a scientist at the Treatment Research Institute. My focus and work has been on developing tools to equip the addiction treatment providers with tools to track patient outcomes and also to deliver evidence-based counseling interventions around counseling and medication. So I'm really pleased to be able to offer you some comments on House Bill 596. I really commend you on this bill. It's very needed. The BedMed registry is going to make it simpler for evaluators at crisis response centers and intake units to identify which detoxification programs or residential facilities a patient can be referred to, and to find one that's ready to actually receive a patient the moment that the patient is ready to get the care. So I'm going to just make 3 suggestions that you might consider adding to the bill or to make it a little bit more expansive, informative, and patient-centered. So first off, I'd suggest that you widen the scope of the registry to include outpatient and methadone treatment. The bed registry is currently limited in its formatting to tracking and informing intake workers about the availability of residential and detoxification placements. And this is a really important step forward. We can't dismiss that. But one byproduct is that the bed registry might reinforce the mindset amongst intake workers and patients that being admitted to an inpatient or residential facility is the preferred way to be treated for addiction treatment. And meanwhile, methadone maintenance programs, intensive outpatient programs, and partial hospital programs have made great strides in formatting their programs to address opioid use disorder and to meet those urgent needs for people who aren't required to be housed or don't have to be in a controlled environment. So the legislation should be expanded to include a listing of the outpatient treatment programs and service providers, as well as current MAT slots available at that facility. This is going to assist intake workers and patients to think flexibly about all the treatment options when deciding on the best referral. So suggestion one. Suggestion two would be to shift the focus away from detoxification to the concepts of withdrawal management. So my second suggestion on the legislation is to try to promote that new terminology and a new mindset away from the mentality of detoxifying a patient towards managing the withdrawal symptoms that they're going to experience. Withdrawal management is a more encompassing term that's descriptive of how addiction medicine is being practiced anyway. Currently for opioid use disorder. So for example, a patient might check into a residential program and be placed on a maintenance dose of a legal FDA-approved medication like methadone or buprenorphine to manage their withdrawal. One patient at that facility might be maintained on that dose throughout their entire residential stay, while another patient might be slowly tapered off that dose pending their withdrawal symptoms and what their provider thinks as they're going through the process. So that patient might then be discharged opioid-free. Furthermore, some patients and providers might decide that opioid-free patients, when they're being discharged, should be given an injection of slow-release naltrexone to prevent relapse and to prevent overdose risk when they leave after discharge. Now, as these three small little examples illustrate, the course of care around medication really differs based on the patient's needs and the provider's willingness and capacity to meet those needs around withdrawal symptoms. So withdrawal management can be accomplished in methadone maintenance and outpatient settings as well, and including that in the bill language would support that. Therefore, each participating agency in the registry should also disclose what their withdrawal management capabilities and philosophy are, so that intake workers and patients can make patient-centered, informed decisions about where they want to be referred for their care. So my third suggestion on the bed registry legislation would be to augment the registry with some patient-centered information to inform their care decisions. Now, because withdrawal management can take numerous paths for a patient, it's important that mandated treatment providers who are listed in the registry should also provide some up-to-date statistics indicating typical course of care related to their withdrawal management and their patient outcomes. This information should be made available to a patient who's considering complying with a referral at the listed facility. The information could include things like their completion rates, as well as retention rates at 30 and 90-day thresholds. In addition, the treatment provider should disclose what percentage of their patients who qualify for medication are actually offered the medication and choose to receive the medication, because that speaks to the climate of what's going on at the facility. And this could be broken down by what percentage of patients are offered medication to taper off of an addictive substance and what percentage are offered ongoing maintenance doses of FDA-approved medications to manage their withdrawal. And finally, what percentage of patients are discharged on agonist medication and what percentage are discharged on antagonist medications. This information is important quality information that are quality indicators that could impact a patient's willingness to receive a referral and paint a clearer picture of what a patient can expect when they're referred to a treatment facility. The information should be available to a treatment seeker and updated at a minimum of every 6 months. Thank you for the opportunity for PHMC to represent and to testify on the bill, and we're pleased to be part of the conversation, and of course we'll be around for questions.
Thank you.
Thank you very much for your testimony. Our next testifier will be Deb Back from a treatment provider's perspective.
Start today, huh? Oh, Lord, lots of stuff. I want to start by thanking this committee. You've done some very concrete things. Hi, good morning. Haven't seen you for a while. Haven't seen you. You've done some very concrete things in the past that have made a huge difference. And for those of you who are new, this is the committee where Narcan got its start. And your action started here. 20,000 lives have been saved in Pennsylvania. That's just the ones that they can keep track of. You've saved lives by that. So I don't want the new members to think, oh my goodness, this is so complicated, and there's all these high-tech, complicated phrases. I'm not going to read, so you can look at testimony later. First of all, thank you very much. I'm looking at the chairman. We have 3 chairmen today, I think. We've got DiGirolamo, Cruz, and we've got a new chairman here on this issue, Representative Heffley. I am Deb Beck. I'm with the Drug and Alcohol Providers Association. We have a statewide organization of prevention and also all kinds of drug and alcohol addiction treatment. And it's available in most of your districts. If I can help you later, I absolutely promise I will malinger in the halls if you have any specific questions in your area, or if I can help, because I know you're going to disappear like magic off into the floor. First, I want to start by expressing our appreciation as the drug and alcohol addiction treatment field to the emergency responders in all of our counties that are saving lives every day. This is incredibly hard work. I'm surprised that they're not all going for psychological counseling to support what they have to do every day. We are so grateful to the police and the EMS and the emergency room personnel that save lives. Wanted to also thank you for the opportunity to be here to testify in regard to 424, and to thank Heffley for your ongoing interest in this crisis that we must address and your continued commitment. I think it's appropriate that you are focused on overdose survivors. Overdose survivors are high risk to die later from addiction if we don't do something about it. And in 1 in 4 families in your communities, in my neighborhood and yours, today is wrestling with how to get an untreated loved one into an addiction treatment program. And I don't know if Representative Struzzi is here today. I haven't met him yet. That's you. You're right. We don't have enough beds. Flat out, you're right. You can have a registry, but if you don't have enough beds, what are you going to do? We don't have enough beds that are immediately available when the patient makes a decision to go for help. This is a disease of urgency. If you fool around and you delay, which all of us have done in the past, the patient could die, or I could do damage to my family. So 5,456 people died in Pennsylvania in 2017 of overdoses. 5,456. Imagine the grief going on. Imagine the pain out there. I listen to it every day. I hear from the families. So 2 provisions of your bill really strike us as really important, and a lot of important stuff was said here today. But first of all, you're requiring that an overdose survivor list, or overdose survivors, go immediately on the special populations list for treatment through the federal drug and alcohol block grant money that comes into the state. Absolutely imperative. There are other populations on that list. Who are they? Pregnant, addicted women. Oh my gosh, kind of an obvious one needs to be there. So are homeless veterans. But let's add overdose survivors to that list. I think that's absolutely imperative. The second part of the bill that got our attention was you're asking for the elimination of pre-authorization requirements. Please do that, but don't just limit it to the commercial insurance side. Do that for the rest of the system as well. You do not want our patients caught up in a lot of back and forth with insurers and managed care entities on both on the public side or private side while the patient's dying sitting out front. You don't want to do that. Whoever came up with that, brilliant, do it. Put your checks and balances later in the process, never at the front door. This isn't like people don't go sign into drug and alcohol treatment because it's fun. This isn't something where you have to protect the world from the addict getting treatment. But sometimes I think our system has been designed to protect the world from the addict getting treatment instead of getting the addict into treatment. More on that in a minute. We do want to raise one major concern, and I already hinted at it. Overdose survivors are fragile, 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 fragile. They are not going to recover through stabilization and detox, which was already mentioned. Stabilization and detox are not treatment. It's the beginning to get the cobwebs out of the brain so people can begin to engage therapy on some level. They're not going to recover. And the odds of somebody coming from a detox to an outpatient clinic and surviving is not great in terms of staying clean. Again, if I'm sick enough to end up in a detox, I'm probably going to need the whole array of residential, outpatient like crazy, halfway houses, the whole thing. Not likely that I'm going to survive going from detox to outpatients. Probably not going to happen. Now, by the way, most people with addictions don't need residential. Most go to Alcoholics Anonymous, Narcotics Anonymous, they go to outpatient, whatever, and do fine. But for people who have managed to end up in an overdose in a hospital, probably not going to make it. That's why the bed issue becomes so terribly important. And it must be available when I need it. It can't be available 2 weeks from now or in Erie when I'm in Montgomery County. They need to be locally available, and that's an issue. I would have concerns about licensure in terms of stabilization units. A lot of those concerns have been raised earlier. We are very much in support of Representative Gregory's resolution that calls for pressing empty state hospital buildings into this service because they're kind of located around the Commonwealth in places that might be available to fill some of these gaps. So I would add that to the list of things to consider. And frankly, friends, if we really wanted to do something about the drug crisis here in Pennsylvania, there's a lot of stuff we could do in addition. There are many other things. For example, eliminating all the admission stuff that gets in the way and hinders admission into drug and alcohol treatment. It's an incredibly bureaucratic process at the front door that catches our clinicians when they'd rather be doing clinical work. On the insurance side, why wouldn't we tell insurers, you must tell your subscribers what their coverage is for addiction treatment and how to access it? You know, we've had flus and viruses. One-page flyers weren't out of the question. And I certainly know my insurer sends me that one-page flyer when they want me to know that there's a premium increase. So why not a one-page flyer that says, hey, Deb, here's your drug and alcohol coverage. This is how you access it. If you can't access it, call your single county authority. People can't find it in the books many times. Finally, in closing, I'm sure you're sitting here thinking, oh my God, this is going to cost a lot of money, right? You're worried about cost, and you got to be. But I want to tell you what the research shows us in terms of cost. The cost of untreated addiction, untreated drug and alcohol addiction to America has been conservatively estimated as $428 billion a year, and annually renewing $428 billion a year. We call that the price tag of denial. America's price tag of denial. We would rather pay for car wrecks and burying people and putting them in jail than to deal up front with the illness. $428 billion. Pennsylvania prorate is $17.1 billion. We're wasting $17.1 billion. Now, by the way, that federal number is just the easy to measure stuff. Just the stuff like car wrecks and criminal justice costs. No one has found an ability to put a price tag on the broken heart of a mother whose kid has died. We haven't begun to talk about the measures and costs that could be in here. What about the other side of the equation? Moving from the price tag of denial. The research is conclusive. By the way, I've been in the field since 1971. Can you imagine? Think about all the human beings and going to treatment that come through our door since 1971. I just want you to know I've been around a while, kind of seen this, the ebbs and flows of this problem for many years. There are things we could be doing better. And again, you started in the first place. Narcan saved the lives. But what does the research show you about the cost of addiction treatment? It's a very interesting illness. It turns out that it costs large amounts of money in health care, the untreated, large amounts of money in criminal justice, and large amounts of money in the workplace. If you treat it, if you treat the addiction, it's always cost beneficial. It always pays to treat this illness, and your savings will be realized in the area of healthcare, in the areas of reduction in crime, and also workplace difficulties. The research is overwhelming. So it's kind of interesting. You know, if you put the accountant's eye shades on here and think, I can't stand these people. I can't stand people with addictions. A lot of people feel that way. Well, even if you don't like people with addictions, why the heck wouldn't we do the right thing financially? And I've discovered there's something bigger than denial and stigma around addiction. You know, about something bigger in America I thought was money. I thought if we could demonstrate it was cost beneficial, we could get by the stigma. I've been wrong. All these years in the field, I've been wrong. We would rather pay for the mayhem than pay up front for the illness. So I think it's a nice opportunity to do the right thing, and at the same time, it's going to realize some savings for the Commonwealth and certainly heartaches of family. 5,400 people lost their lives to this illness last year. The numbers aren't in, that's 2017. The numbers aren't in for 2018. We think it's going to be around the same. So I thank you for your time. I promise I will linger if any of you have any questions that are specific to your area. But you're Representative Gregory. You're the guy with the state hospitals. Thank you. And you're Representative Struzzi, and you're the guy who's figured out we don't have enough beds. And Doyle Heffley, thank you so much. I think we really particularly would like those two provisions and wonder if we could even move them separately. Thank you.
Thank you, Deb, and thank all the testifiers today. Just a brief, I'll speak briefly here. House Bill 424, the significance of the bill, the young lady, Gabby Green, daughter of one of my staffers that passed away last April from an overdose. And that's why we chose that number for the warm handoff bill. And I do believe that we could save many lives if we can develop this warm handoff. I know one of the first hearings I sat in on this committee was on the prescription drug monitoring program back in, it was 2011, and now that is up and running. The naloxone that we had worked on and passed on the floor to get that out into the public, and also provide family members of loved ones with addiction to have that in their house. And now, we hear from a lot of folks, and we're reviving people, we're saving lives, but what's the next step? And through all these initiatives and everything that we've done, it's been the next step. The first thing is saving lives with naloxone. Now the next step is how do we get those folks with non-fatal overdoses into the treatment that they need, and that's what the warm handoff legislation is for. And I don't believe we could have a warm handoff legislation without a bed registry to identify where those beds are. There's definitely a shortage of beds. I think a lot of the suggestions that we heard here today were great, and that's what this is all about. House Resolution 659 from, I think it was 2016 or 14, put together the opioid task force, and we moved a great package of legislation, including the PDMP, the 7-day limiting of prescribing in ERs, and I think one of the main things was the Medical Society coming out with the prescribing guidelines for opioids. So we are making a lot of progress, and I think this is naturally the next step. We needed it 2 years ago. We need it this year. So we still have a lot of work to do. And I thank everybody for coming and testifying today, and would invite everybody up. And we have a number of members that have questions for the panelists today. So I don't know if everybody can kind of filter up to the front at the table, or if that would be possible. All the testifiers.
Move some of them chairs around
We can,
too.
yeah, we can move some of the chairs around as well. I also want to thank all the committee members for being here, and Chairman DiGirolamo for allowing this hearing, and for me, the subcommittee chairman, to be here and part of it. Chairman DiGirolamo?
Yeah. Okay. Again, we're going to open up for a few questions, but just one comment, because I've heard it from almost all the testifiers. I mean, I put an awful lot of people in treatment, and people who call my office, and I'll tell you, over the last few years, trying to find a detox bed over the weekend anywhere in the state of Pennsylvania is a challenge. A lot of times you cannot find a detox bed. And I'm a firm believer that people that want to get into treatment and their families ought to have options of what type of treatment they want to get into. And, if they want to get into residential rehab, they should have that opportunity and option to do that. And Deb Beck mentioned Representative Gregory's piece of legislation to do a study on these closed down, shut down state office buildings around the state. And I really think that there are buildings out there that we could open up and get treatment people to go in there and run those buildings if we can get them rehab. Because everybody knows you got an addict and the family wants to get them into treatment, and you're sitting there on a Thursday and Friday and they want to get in, and you can't find a detox bed, and you're going to tell them to call back on Monday or Tuesday. That's not going to work a lot of times, because they're just going to go right back out on the street, keep using, and you're not going to find them. When somebody needs to get into treatment, you got to have a place to put them and a way to pay for it a lot of times too. I mean, so, treatment beds, we've got to get more treatment beds open in the state. It's critical because people are dying because they can't get into treatment, and make sure that we have a way to pay for it too. So with that, I'm going to open up for questions, and first I'm going to Representative Cruz.
Thank you, Chairman. First of all, thank you all for giving us the opportunity to give us your feedback and your information. The concept that I believe in is that in order for you to come to a solution, you got to talk about the issue. So this is what we're doing, okay? Number one is that everything that we do to help folks get treatment is costly. But one of the solutions is that we talked about in this committee that we need to bring back is how do we tax the opiates pharmaceutical industry, okay? They are responsible for giving these medications and these drugs to people that become addicted. The second part is how do we come after them legally and hold them responsible, file charges against them. What is the difference by an actual drug dealer in the street than a pharmaceutical industry that is selling and giving away drugs that are addictive and not being held responsible? We're a legislative body. We legislate the law, and I think it's time for us to do both. Do a tax where we use the monies to help people that became addictive to their product, but we also find a way how to hold them responsible legally so this doesn't occur. Yes, we're running out of beds, okay? And the testimony that I heard was from Allentown, Lehigh Valley, and Reading, but you haven't talked about Philadelphia, the city of the first class, okay? Where we have all these encampments. And someone came up with a solution of saying that let's have a safe needle injection site. That does not work. If these people do not feel safe, they're not going there. We'd rather have more beds and more treatment to help the people, okay, than starting resolving and creating other things that are part of the problem. So I thank you for talking about the issue. Now it's our responsibility to roll up our sleeves and do the people's business that they send us up to here to do, which is to protect our citizens in the Commonwealth of Pennsylvania. Thank you, Mr. Chairman.
Representative Nelson.
Thank you, Mr. Chairman. Complex and broad testimony today, and my initial question is focused on the Blue Guardian program, and also just wanted to comment a little bit on some of those roadblocks for individuals. Particularly, somebody had mentioned in their testimony about individuals struggling with alcohol addiction, and it's difficult for somebody who's not drunk to be able to get in. Like when they are recovering and they're sober, and then they try to reach out, they don't qualify to be able to get back in again. And I've had multiple people struggle with being able to get into a program because they had hit a trough, were sober, and then not able to get into active treatment. So I don't know if, these bills don't touch that, but as we get into roadblocks, another roadblock that I hear from private treatment providers is that they are struggling to be approved to treat those lower income individuals, at least in Westmoreland County, where they have a desire to, their private practice, and they have a desire to expand into there, but there are some roadblocks in allowing them to get access to be able to provide that treatment, and they're willing to do that over the weekends, with those registries. But could you touch on a little bit specifically we don't have in Westmoreland County a Blue Guardian type program, and we're looking to try to integrate and develop. How, from a confidentiality standpoint, does all of that information between names, addresses, you had mentioned some mental health, from the DA, toxicology, individuals struggling, how does that, is it an app? Is it a computer program that's provided? And what is an approximate cost of implementation of that program? It sounds very effective, but can people really share all of that information? Because it seems to be a struggle point, particularly from physical and mental health side.
So yes, it is an application. It's a web-based application. We have over 1,200 users across 2 counties. Everything is handled through role-based security. So only individuals that would the coroner, for example, would allow to see his information. Only those individuals can see that information. We can see summary reports that he wants to present to us, but for the purposes of this presentation, I wanted to show you what it would look like when his staff enters it. Same with the clinical notes. So Lane and his staff, the single county authority and the certified recovery specialists, they can see the clinical note information. Law enforcement cannot. Just like the clinicians, they can see their information, but they cannot see the law enforcement information, if that makes sense.
So within our hospital system, they have their own Meridian, I think it's called, or they have their own system that they're using to enter and billing. Is this an additional system? Like was there pushback from the hospital providers to, that there's now another database that they would be entering in information?
No, the hospitals aren't entering any of this information into a database. That's all done either by police creating the naloxone report, which is a report that they're required to fill out anyways for PA Odin. So instead of doing the handwritten report, faxing it into PA Odin, they're able to access it from their cruisers, type in the information, hit submit. Part of that report that's appropriate goes to PA Odin. The rest of it comes to my office as the SCA. So the SCA's office really drives the boat on this. We then contact the certified recovery specialist. They go out and do the house call. We get the clinical notes. The SCA's office puts the clinical notes into the system. So the hospitals don't do any of the data input. But what we've done is that we have a different system that, again, is maintained by my office that manages all those 2,200 warm handoff referrals. It's called REDCap. It's a free web-based application. Confidentiality is part of it. It's role-based access. So St. Luke's can look at St. Luke's, Lehigh Valley can look at St. Luke's, but they can't look at each other's patient data. But they're able to share information that way on aggregate totals. We're able to take that information, do a data export, and then run it through the REDCap so we can further develop what does the drug trend really look like per zip code or per city block in the county of Lehigh.
Thank you. Thank you, Mr. Chairman.
Representative Pollinchuk.
Thank you, Mr. Chairman. This is more of an offer than a question. Obviously we know the opioid epidemic, it touches all demographics, rich, poor, urban, suburban, rural. It certainly touches my district in Central Bucks County as well. And this issue, I think, is just too important to move slowly on. So with regards to the testimony from Dr. Beauchamp representing the hospitals and specifically the Lehigh Valley Health Network, and with your permission, Mr. Chair, I'd like to take the lead in getting the ball rolling on forming this task force, the Overdose Recovery Task Force. I'd ask that my colleagues jump on board and that anybody that has a willingness or expertise to in this field to please get your information to Melanie so that we can get up and running immediately with this. Thank you, Dr. Barbera, for having the emergency room physicians want to jump on board with that as well. So that's much appreciated. And everyone that traveled so far today to brief us. Ms. Beck, no doubt your passion has saved lives, and thank you for the work that you're doing. So thank you, Mr. Chairman.
Representative Gregory.
Thank you, Mr. Chairman, and thank you all for being here for your testimony today. This is an all-encompassing subject. Representative Heffley, thank you very much for putting this bill forward, and the opportunity to talk to you today is why I ran for this position. Anonymity is a big part of what we do as addicts, and living in long-term recovery for 9 years and having lost a brother to overdose 30 years ago, if I get nothing else out of this, the opportunity to be a representative here to talk about this today, then I would be fine with that, because this is a huge problem for the state of Pennsylvania. And for the opportunity to repurpose state office buildings, to find space so that we don't have barriers to people who need the help is crucial. It is absolutely crucial. In the late 70s, we closed mental health hospitals in Pennsylvania and turned them into veterans' homes. Our veterans benefited from that. So what are we willing to do for our addict community to make those spaces available for them now? So I really appreciate the opportunity to put that proposal forth and the staff that's helping with that, and I would encourage my colleagues to sign on and also add their co-sponsor names to that resolution. So just a couple of quick questions. First of all, when it comes to the cost, in Blair County raised taxes 2 years ago. And one of the reasons they raised taxes was because for those people that have not lost somebody to addiction, they should count their blessings, but they're paying for it. You wanted to know, Deb, about costs. Parents who are parenting, grandparents who are parenting, foster kids in Blair County. In Blair County, we had the largest number of foster kids that we've ever had last year. That's a cost to taxpayers. Autopsy and toxicology reports increased. That's another cost, an increase that you're paying for. So with that in mind, I would just encourage you to also include that in conversations about those that look at stigma and are taking people and not being willing to recognize how we can help them. For those in the healthcare field in hospitals, when we're looking at areas where we need to address possible holes in the system, can you explain to me whether or not we have a HIPAA problem in our system, whereby emergency room visits for those who are on naloxone, Suboxone are coming in, and the PDMP does not recognize those that are currently receiving it because of therapy. They are protected by privacy. That those folks, when they come in, are being given an opportunity to either relapse or receive treatment and not use it there, but take it with them. Can we recognize whether or not we need to look at our HIPAA policies? Maybe it's not a state, maybe it's more a federal issue, but if we need to recognize where the holes are in a system where when you come into the emergency room that you are not recognized on the PDMP. Is the PDMP fully helping the situation? And I'll just throw that out as one question, first of all. Anybody that would like to answer?
I would say that the PDMP is helping.
Okay.
And I say that at least at our, I don't want to get arrested, but we've decided that HIPAA is last. We've decided that we're going to treat patients for the best of patients, and we would fight a HIPAA battle if we needed to, if we felt, the physician felt that it was in the best interest of the patient to look at someone's past medical history, and that's what we're calling this, the past medical history for their treatment. And so I think that's very important, and I would offer one suggestion to all of us with regard to stigma. We've learned, at least, is that the word addict itself is not a positive connotation. So when you come into the emergency room and the triage nurse said, "Oh, we have an addict in room 5," that is very different. All of a sudden, all of us have this preconceived notion of what that patient is. So we've changed our terminology, and we say, well, we have a person with an addiction. Person with an addiction, much like a person with diabetes or a person with a heart attack or a person with a laceration. Because we've kind of found that we were taking this disease and we were segregating it. We were saying, well, okay, addiction's here and all the other medical problems are over here. And we're going to treat all the other medical problems because if you have a stroke, we don't really care about HIPAA. We just do our stroke stuff, right? And then we figure everybody wants to get help for a stroke, right? So we've struggled a little bit with our single county authority with regard to what information we can release after the visit, but during the visit, it's not at least for us, it's not an issue.
Thank you. And as far as, I'll be brief, I want to allow other questions, but as far as the behavioral health issue, the mental health issue, we didn't hear too much about how that plays a role, but then we also get into a workforce issue, and in my county, we have a difficult time finding certified recovery specialists. We have a workforce issue all in just about every industry that we have in Pennsylvania. Can you talk about what we need to do as the state, the Commonwealth, to be able to recognize how to encourage more folks to be a part of wanting to be participating in helping this from a workforce issue? Thank you.
Well, I mean, just one point would be that salaries, pay. Yeah, I knew you would amend me on that.
But workforce is an issue, correct?
It is a major issue, and I think one of the issues that I find in the work that I do is the turnover rate. Is people enter the field, they're enthusiastic young people with degrees in counseling, or want to do good, but it does not pay, and the paperwork is crushing. And so those two things together drive people out of the field really quickly. And I think you've probably seen it too, Deb, in your perch. We really need to be starting to think about paying for addiction treatment the way we pay for other health services. And right now, the rate for reimbursements for services is low enough that we just can't keep addiction treatment agencies staffed at competitive salaries. So people leave to go do other things. And we wind up training people who may not be as qualified and just hoping we can train them well enough to do the job and that we can retain them long enough to stay in the field. Deb, do you want to add anything?
Yeah, I do. Thank you for asking that. I think when you've got there's a workforce problem everywhere, you're correct. But I'm sorry, our folks are dying. I think if I prioritized where I'd want to see workforce dealt with, it would be here. You have in the audience Bill Stauffer from the Recovery Organization, who works on workforce papers, and he's done surveys, and he'll correct me if I'm making an error here. I ran treatment programs. I ran a Skid Row program for a number of years. Easily, the best counselors were recovering addicted people who also then had gotten training in counseling. Easily. The social worker types, and I is one, and the human services types, after a while, the stigma around the illness becomes overwhelming, and the salary is one of the issues, but the other is the whole field stigmatized, and it's like, why are you working with those people, and why don't you go do something with people who we care about, and they eventually leave. Also, the undergraduate training, and I have both a bachelor's and master's, is incorrect in health and human services on drug and alcohol. It doesn't teach it's a disease. It's still teaching it as though it's something to do with your mother or your father, and when you have someone having a seizure, you figure out, well, gee, that probably didn't have anything to do with his mother or his father. The training is not very good in the colleges. There's some improvements. There's some colleges that are beginning to do this. Loan forgiveness is what we ought to be doing, frankly. People who are in the field and stay, Bill Stauffer's surveys have shown, my own experience working in the field, is the people who stay day in and day out are usually in recovery or family members of people in recovery. But it's usually a second career. There may be criminal charges for some. They're raising families, have a house. They're going to need support and time to get out to school. The loan forgiveness is imperative. And given this is who's going to be there on the front line, that's who many of the certified recovery specialists are. I think we need to spend the bucks there.
Thank you. And I'll just finish by saying that as we look to try and limit the barriers, looking for more space, looking for more money, we can do all of that. But when an addict comes in and they don't have somebody to talk to, it's a barrier. And so we need to address that. So thank you. Thank you, Mr. Chairman.
Okay. Representative Hohenstein.
Thank you, Chairman. I want to start by saying that I, along with Representative and Chairman Cruz, represent Philadelphia, and we had 20% of the overdose deaths in the state, according to the last measure. We're living with a little bit of a different reality. I was listening to the Blue Guardian program, wonderful, but a lot of our people living in addiction are living on the streets as well. So one program I want to note that the Philadelphia Police Department has started is a police-assisted diversion, which is essentially the triage version of what we just heard described by the Blue Guardian program, which I think also is really good. I have two questions, one regarding House Bill 424 for Dr. Dugosh. Did I pronounce that right? Dugosh. Okay. I'm Hohenstein, so I'm sensitive to to issues of pronunciation of my name. When you reference MAT as the gold standard, I'm a Philadelphia Eagles fan, and gold standard makes me very uncomfortable as a phrase. It's not exactly something that I'm comfortable with. But what I'd like to ask you to do is just describe that, because I've heard it described from the Secretary of, I think, Health, Secretary Levine, as medically assisted treatment wrapped around with counseling and therapy and then intensive case management. And I'd like you to just make certain that that's the description that we're talking about when we talk MATs.
That is what I'm talking about. Research consistently shows that these medications are most effective when they're provided within the context of comprehensive psychosocial treatment and service provision. Medication alone is better than nothing at all, but people tend to have the best outcomes when they receive comprehensive wraparound treatment along with medications.
And that requires a deeper initial investment into the person's treatment, correct?
Absolutely. Because
Yeah.
you find that individuals who have opioid use disorder, that's not the only problem they have. They tend to need housing often, especially in Philadelphia. They tend to need they have family issues that need to be resolved. So providing comprehensive wraparound treatment is important.
And what would be your opinion of how we should handle the departments, what they call the Center of Excellence? They have about 40 or so of them around the state. We didn't talk about those in this context, but when you were talking about only sending people to facility, or not sending people to facilities that will do abstinence only, how does COEs fit into that?
I think the COEs, at least the COEs that I've worked with, tend to have more comprehensive treatment available, and they tend to have better outcomes for patients. In the work that I did, a comprehensive evaluation of Bucks County's Warm Handoff program, and we found that when hospitals have an associated center of excellence, individuals who receive the Warm Handoff were more likely to have more positive outcomes. And the work that I've done in Philadelphia seems to suggest the same thing. So I do believe that the centers of excellence are having an impact. But again, I think it's important with all of these initiatives to comprehensively evaluate whether or not that's the case by looking at the numbers.
Thank you. And I just have one further shorter question on House Bill 596 for Dr. Beauchamp, and I think also for Ms. Beck, relating to the concept of how the registry treats whether a facility will accept Medicaid or medical assistance in any way. How do we improve that, or what do we need to do with the bill to make certain that that's clear?
That's an excellent question. We do find that at least in our treatment program, the vast majority of the patients are covered by Medicaid, or our program helps them to apply for medical assistance, and then during that transition period, we rely on county support for the treatment until that coverage comes through. So while I don't have the perfect answer here, I think what is absolutely key is that we have access to treatment providers who are willing to accept patients in that very tenuous period. So there can be 4 to 6 weeks when the patient has no coverage at all, when they're uninsured, and when medical assistance is pending. And that's where county support has come through in our region. But once the patient is covered, does have Medicaid, where there is a treatment provider who accepts that coverage, we are able to engage that patient in treatment. So the key really is finding adequate numbers of treatment providers, facilities who accept Medicaid. And I do want to be clear that that doesn't necessarily mean that those all have to be detox or inpatient rehab beds. In our program, because we use medications like buprenorphine, so medication-assisted treatment, we are able to stabilize patients without them necessarily needing an inpatient stay. So we actually have a cost-effective approach that involves avoiding that very, very medically challenging detoxification period. And instead, rather than putting the patient through that, we're able to put them on a medication that actually makes them feel relatively normal, allows them to engage in treatment, and they can then participate in something like a partial program, intensive outpatient. So maybe 1, 3, or 5 days a week rather than relying on the availability of an inpatient bed.
Okay.
And so we've worked closely with the county to work with those limited resources.
If I could jump in and clarify something, though, from the single county authority's perspective, I have contracts with numerous providers for both detox residential beds. I have 7 beds on hold tomorrow. I have 5 beds on hold for Thursday. So I'm not sure from my perspective what a bed registry is going to do, because I know what the capacity of my treatment providers are, because I have those contracts. I work in close relation with them. They know how many individuals are in detox. They know as they're going through the continuum, day 4, day 5, they're stepping down. I'm already reserving those beds 2 days out. So I don't know if our patient bed registry is ever really going to catch up and give us a real life number, what's available this morning. Most of our treatment providers do send us an email every morning around 6:30, 7 o'clock in the morning, giving us an idea of what their forecasted capacity is. Now, if there is an AMA or therapeutic discharge, they already have somebody on hold or standby that's filling that bed. They'll never update that registry. So I think it's a great concept and something that allows us to continue these conversations. But practically speaking, it's not going to provide Lehigh County any assistance whatsoever, because we already have them booked out for 2 or 3 days.
All right. One last thing I'll mention. In Philadelphia, when I talked to the mayor, and I asked him, if there's one thing you want to make sure people in Harrisburg understand, and he said yes. Beds. So we need them, but you're right. We do need to adequately track them. We have a different problem of volume in terms of the tracking, and I think a registry would help us. But thank you for giving me so much time, Chairman.
Representative Hohenstein. I'm learning all these new names. I'm working on it. Back to the state hospital idea. You know that the state's already paying to maintain empty buildings. They got to. They're sitting there empty. You're already paying for it. And you have state hospital beds and programs like that in Philly. And I think you ought to open the doors. I mean, what are we doing? Are we serious or are we playing here? Even if you don't like addicted people, it's like a virus. You want to stop it before it gets any bigger. You need to open the doors, get the treatment in there, hire lots of recovering people, make mistakes, but get people off the street. We had a natural experiment with that back in the 80s, where there was an opening of beds in Philadelphia, and what happened is a crime wave. The crime went down in the area where the beds were opened up. Well, no kidding. If I'm involved in crime, and most addicts aren't, by the way, they're more like Betty Ford. I always have to say President Ford's wife now that I've gotten older. Kids in school don't know who I'm talking about. Don't commit crime. Our people just die quietly of desperation more often than not. But gee whiz, in Philadelphia, why wouldn't you open the doors? Open the doors. Let's make some mistakes. Let's get the people in there. You're already paying for it. And again, one of my fears about your bill, Representative Heffley, is I'm afraid it'll work. We can't handle what we got now. So dealing with where we're going to put them is just imperative. Thank you.
Okay. Just a quick comment on these MATs. And I'm not anti-MAT. There is an absolute place for MATs. And I think in the state, we're doing, as far as methadone goes, we're doing a really good job with methadone maintenance treatment. And I think there's a lot of docs out there with the Suboxone that are doing a really good job as well. And they're including, as you mentioned, counseling along with the Suboxone. But I want to tell you what, we've got this Suboxone all over the street down in southeastern Pennsylvania and in other parts of the state. And you know how it's getting there? It's getting there because it's being diverted from people that are going to these doctors, are getting no counseling. They're in and out of the office in 5 minutes, taking home their prescription. They're diverting the drugs, and addicts are the most entrepreneurial people that there are. They figured out they can sell their 30 strips or pills of Suboxone on the street and make money and continue to use their drugs. And it's really out of control. And the doctors are taking cash. They don't want to accept insurance. they're charging $150 to $200 a pop and seeing 100, or I don't know how many they're up to right now, 100, 150 patients a month, hiring doctors that are retired to come in for a day or two a week so they can see more patients, and they've got a great business going on. So if you're going to do this Suboxone without any counseling, I mean, we've got to get our hands around this. It's all over the street. Addicts are telling me to get all the Suboxone you want, and it's being diverted because they're going to their docs, getting a prescription, and going out on the street and selling it. We've got to get a better handle on what's going on with the Suboxone around the state. Okay, we've got about 15 minutes left. Representative Strucy, then Representative Glenn for questions.
Thank you, Mr. Chairman. Try to keep this brief. First of all, thank you for being here. I appreciate the work that you're doing, and there are professionals around the Commonwealth doing great work. And I think it's important that we understand what legislation means to you on a day-to-day basis before we enact anything. This discussion for me has been very painful. Every time we talk about this subject, I see my brother in his coffin because it was only 4 years ago. And I think that we're talking about some of the key links that are missing in the entire treatment and recovery process. And the process is what we need. So I applaud Blue Guardian. I think that the step-by-steps that you showed, the linkage between Narcan and treatment is fundamental. I see it in our county, Indiana County. And Narcan's saving lives, but we've got to get to the point where we don't need to continue to provide Narcan. I think we need to do this discussion to let's start talking about prevention as well. I think that's where we need to be at some point. But 5,000, 5,400 lives lost every year is to me, there's no cost that we should have to be worried about to cover this, because the cost to our communities, the cost to families, I know what it did to my parents, I know what it did to our family. Representative Gregory, I understand Jim's point as well, and everyone who suffers through this. So it's very pertinent that we have this discussion. I applaud Representative Heffley for pushing these legislations forward. But I have a couple of questions, I think, pertaining to, first of all, Blue Guardian. I know we want to keep this brief because we're running out of time, but how has that program been received in the community?
It's been received very well, actually. And since we've incepted the program, we've seen a shift in perception from the community about law enforcement. They see them there as now to help, not to arrest. And we see a shift in perception from law enforcement with regard to what addiction is. It's not the face you think you used to know. It's constantly changing. So there's been some very positives that's come out of that.
And is it funded through the district attorney's office or through, go ahead.
It is a combination of the district attorney's office for his staff and support, but it's also funded through single county authority.
Okay. The stigma is still a big concern for me, and I think the stories that you told, some of you today in your testimony, you got to put a face to this, because these are people who simply made a bad decision, or like my brother had a sports injury that led them down the wrong path. So I think if we want to erase the stigma, and the stigma is a big thing, I really think we need to change that. And you mentioned it, Dr. Barbera, in the emergency room. And as we talk about the warm handoff, which again I think is essential, it needs to be warm, right? We can't have nurses and doctors who don't understand this as well. And I've heard that story as well back in my home county. So we need to make sure that as we push this legislation forward, I think all the items in here are so important. I think that's the only couple of questions that I had. Just one more related to the registry. I did share that with some of our treatment professionals in Indiana County as well, and they sort of agreed that there isn't a lot of value in it if it's not accurate. So that's just something that I think we need to bear in mind moving forward. So again, thank you all for being here. Thank you.
Representative Gleim.
Hi, it's Barb Gleim from Cumberland County. I want to thank everybody for being here. I just have a real quick process question to sort of piggyback off of what Representative Struzy was asking. I come from more of a rural area, and so this is going to be, hopefully passed for the whole state. And I know that Blue Guardian's presentation talked about the rural community a little bit. I just got out of a meeting in my district on SR6 and how the EMS are really short-staffed right now. So do you suggest, or do you have any suggestions on a possible consortiums with the EMS in the whole process of this, or is it really the police departments who are actually the ones that are more important here?
I believe it's a combination. I believe it's whoever that meaningful partner is for your community. For us, we had the data with the naloxone program with law enforcement. We had all 17 police departments actively involved. The next step in the migration is to obviously look at volunteer fire companies. What if we train those volunteer fire companies to learn how to make that phone call to that person in the community they know is struggling? And by them making that phone call and having that family agree to a quick meeting, there's no confidentiality issues. We are now have become invited into that home. So that volunteer fire company member brings the CRS into the member's home and provides the support and that same linkage. So we are able to use it with police as necessary, because I think police give us that emphasis that we need, that this was a law enforcement involved naloxone event, so it's event specific. But I also think that this can be a very proactive instead of a reactive program as well, where we train churches, community members, EMS, volunteer fire companies, families, community members. How do you make those cold calls or make that uncomfortable conversation with your neighbor saying, I know you're struggling, but you know what? I know a guy. The guy would love to hear your story. And we bring that CRS in. I mean, when you put a CRS in those environments or put him in a police cruiser doing car therapy with a cop, it changes people's lives. You know, and that's what we're looking for. We're looking for a relationship to be built that we can then springboard access to treatment and these other issues that we need to off. But if we don't have that relationship, we're never going to get the people to stay.
Thank you. That's all. Thank you.
Representative Heffley for follow-up.
Back to Lane Turner. One of the issues we have in Carbon County, very rural, the district that I represent, is with the beds. And we're hearing from the ER, I heard from my emergency rooms about the need for a registry, a need to find those beds. And so I'd like to work with you on that so we can accommodate in many rural parts. And that's another comment that was made earlier about the centers of excellence, but the SCAs are providing many of those services already. So I don't want to duplicate a lot of services. I want to make sure that we're getting the biggest bang for the buck for every dollar we're spending, and definitely working to get those folks in, find those beds that are out there, and especially in the rural areas where we don't have those treatment facilities, inpatient treatment facilities in those counties.
Oh, absolutely. That's where I believe a regionalized approach really comes into play. SCA should no longer think that this is just my county. We need to think regionally. We have a partner with Lehigh Valley Health Network. They're located in multiple counties. So I can't say that my work with the Lehigh Valley Health Network or the hospital stops at the border. But we also have the ability to learn from our hospital partners, because many individuals that are languishing in the hospital system are more appropriate for the substance use disorder treatment system, but because of endocarditis or because of ambulatory issues, our treatment system will never accept them. So what would it look like if we start identifying these patient sets, the pregnant women, create a designated program for pregnant women? Okay, we did that. We just took care of 110 pregnant women. Now, what if we start licensing SNFs, skilled nursing facilities, for outpatient treatment? Take the endocarditis patient out of the hospital, put them in a SNF who only operates at 60% capacity, bring treatment into that facility, and start leveraging the ability of skilled nursing with treatment. Now we don't need to rely on put all of our eggs in that treatment bed basket, but we're creating other competencies and modalities that's going to strengthen our system across. Because remember, we're looking to maintain the balance of that ecosystem. By putting all of our eggs in that one treatment bed balance, we're still going to have an upright system. We need to look at all of those opportunities. So leveraging the abilities of skilled nursing, our hospital partners, we're really seeing more of an impact and less of a need to rely solely on those beds.
Just a couple of follow-up questions. I think I have a couple of minutes yet. The PDMP, is providing a lot of information to doctors. Would it be beneficial if the PDMP could also identify non-fatal overdoses if that was tracked in the PDMP, and also if there was a form of a registry or availability for beds listed in conjunction with the PDMP?
Can I jump in first? It's absolutely yes, but one of the missing populations in the PDMP is our veterans. So if you're receiving care through a VA, the VA, federally, they do not endorse the state's PDMP. So we have an outpatient veterans center in Lehigh County. If a veteran is there receiving medication through the Veterans Affairs Association, is still able to access a community-based provider. That community-based practitioner has no idea that that veteran is receiving methadone for pain management.
Okay.
That veteran's not telling them. They're able to then prescribe a double dose of methadone in an instance because the federal system will not participate in the PDMP. So I think that's one of the things we can begin rebalancing with this, especially with the number of veterans that are in Pennsylvania. We need to have that system fully automated, fully talking to each other, fully integrated, so doctors can then do their job and really do the opioid stewardship reviews that they're doing so well.
And that's why these hearings are so important, to pull that information out. And I thank you for being here. I would just say, because we're going to run up against the time, I would ask for everybody that was here today that submitted testimony, if you could do markups on the bill and get that information over to myself and Melanie with the Human Service Committee, so we can continue to have this discussion and develop this legislation going forward. I thank you all for being here.
Representative Heffley, can I make one more outrageous comment before I let you go?
Sure.
We're talking about money. And I very much ring to what Angel Cruz said earlier. I just want you to know that where there is litigation going on, they have found smoking guns from the opiate industry. There's actually a profit to increase dose chart, smoking gun. We will increase our profits by X amount if you increase the dosage of OxyContin. There's a profit to dose chart in the middle of if you want to see it, in the middle of one of the lawsuits. You want to look at that, and if you're looking for funding for any of these things, I think Angel Cruz is really onto something.
And I think funding and the resources is very critical, and I think it's something that the legislature over the last few years and coming out of D.C. With this current administration has really stepped up funding to a lot of these programs, and we can look for other avenues as well. But I think we also need to make sure that we're using every dollar that we spend to get the biggest bang for the buck, and that's why I really wanted to highlight the Blue Guardian program and how that links. It's like a connection. It's like a link in the chain, connects everything from the overdoses to the treatment and everything else. So thank you all for being here.
Okay. One more. We got 2 minutes left, and I had a question for Deb Beck. Just real quick, 2 minutes. Your membership, you represent members who do residential, do outpatient, and MAT. If you were king or queen of the world in 2 minutes, what are the biggest problems that you see, and what would you like to see the legislature do to help people get into treatment?
I think I would die of the opportunity first. Oh, man. I think we give out treatment of all kinds, like thin gruel to a starving child. That's got to stop across the system. If we really gave a damn about this problem, we would look at policy with that in mind and look at the pain that not dealing with it causes oodles of families and the cost. So I would open the doors to treatment, floodgates. I'd put lots of resources in the department to make sure there's no rip-offs. But how do you rip off treatment when people don't want to go? I mean, this is insane. We have set up an edifice. We have set up edifices to keep people out of treatment. It's time to take them down, open up the doors, and let's get serious about this. If this was a smallpox epidemic, we wouldn't be setting up these barriers. There are barriers everywhere you look. Insurance, Medicaid, not enough beds. This is just crazy. I think we almost look like we have an investment in not dealing with the problem. It's like scary. And at the same time, you got free market. We got the free market industry. I do believe in the free market. It works. But what has happened is it worked to market these drugs in a way the drug dealers never have in America. We have thousands of people sitting out there with their brains sensitized to addiction. They're born in withdrawal. We have created a problem. The good news is we created it. It means we could fix it.
And Representative Cruz touched on this because everything you talked about, I mean, having additional money to try to take care of these problems, if it's law enforcement or treatment, Representative Cruz mentioned it, make these drug companies that created this mess come into Pennsylvania and every other state and help clean up the mess that they started with these opiates. That's what we ought to be doing. Okay, With that, I want to thank everybody for being here, and this meeting of the Human Services Committee is now adjourned. Thank you all very much.